Hello and welcome to the Health and Adult Social Care Scrutiny panel. So today we've got a busy agenda again, so that's good fun. We don't have any apologies, do we?
No.
No. I'd like us to just introduce panel members to start off with, and when we get onto agenda items, if you can introduce your panel then. So I'm Jackie Ramsey. I'm the chair of this panel.
Yes, Councillor Bill Armour, Kirk Burton Ward, member of the panel.
Good afternoon, I'm Alison Munro. I am a councillor for Almonbury Ward. Thank you.
Leslie Warner, councillor for Combe Valley Ward.
Helen Clay, voluntary co-optee.
Kim Taylor, voluntary co-optee.
Jo Lawson, councillor for Crosslandmore and Neverton Ward.
Vivian, do you want to introduce yourself?
Thanks, Jackie. Councillor Vivian Lees Hamilton, Murfield Ward, and panel member.
And Richard.
Yes, I'm Richard Dunn. I'm the supporting officer for the panel.
Okay, we'll just go through some of the basic business to start off with. So, minutes of the previous meeting. People, A, got them, B, read them, and are we in agreement that they're correct? There's just one thing I'd like to note on page 10, if we're okay with that, is that the metrics that we're expecting to help us with understanding the capacity in the community and out of hospital services, we haven't got those yet, so that we're expecting those mid-February, so we'll try and have those discussed at the March meeting. Is there anything else from the minutes of the meeting? No? Okay, thank you, Richard. They're correct. Can I remind any councillors if they've got any pecuniary interest to declare them, please?
Do I need to, once again, yes, that I'm a member of the Calderdale and Huddersfield NH Foundation Trust Council of Governors.
And I'm employed by Calderdale and Huddersfield NHS Trust as a bank nurse.
Thank you. Okay. Admission of the public. They're all here. Deputations and petitions.
None received.
Any questions from the public?
None received.
Okay, so we're on to our first substantive item, and Emily, I think you're going to kind of host it and introduce people. Is that okay? Panel members, if we can keep our cameras on, I think that's just you, Vivian, to be fair, throughout, and as your speakers come on, can you ask them to put the cameras on? Is that all right? Thank you.
Okay, thank you for having us today. It's nice to be back with you in person. It feels like a little while, and I'm not sure, Councillor Armour, we've ever met in real life. I think I've only ever seen you on a screen, so it's a nice addition. So what we're going to do today is I'm going to talk you through some data that sets our conversation about inequalities in access to healthcare services in its context. Some of this data will be familiar to some of you as panel members, but it's been updated, so we are confident that this is giving us our most up-to-date picture. There are a lot of slides to get through, and we are going to be going at pace because we want to give ourselves some time to have some conversation at the end. So some of what I've given you in the slide deck is for your information and for you to take away and reflect on and think about outside of the meeting. I'm not proposing to go into lots and lots of detail because we will be here until a week next Thursday if we do that, so doesn't seem like a good use of our time. If I just very quickly move on to the next slide, Rich has given me a doodad, so hopefully that will work. So yeah, so we're going to update scrutiny on the picture of inequalities across Kirklees. We're going to give a brief overview of the approach that we need to take to have the greatest impact on the health and well-being of the population, and then I have some friends and colleagues with me. So I have Anna Basford with me, who's the Direction of Transformation and Partnership at Calderdale and Huddersfield Foundation Trust, and Anna's got a few slides where she's going to talk about the Trust's response response to the inequalities data. I've then got Carol McKenna, who is joining us on screen from the Kirklees Health and Care Partnership. She's going to talk through a bit of the partnership's response. I then have Sean Rayner, who's the Director of Provider Development at South West Yorkshire Partnership NHS Foundation Trust, and you win the prize for the longest title. And Sean's going to give us a bit of an overview of how his trust are responding to inequalities. And then Andy Petrie, who is the Chair of Third Sector Leaders, is going to talk to us about the VCSE's response. And then we are going to rattle through all of that, and then we're going to have some time at the end for a discussion with a fair wind, and as long as I crack on. So I just thought it was worth setting our conversation in its context of what are health inequalities. And some of you will have seen this slide before, but I think it's really important that we remember as we start this conversation, they are avoidable differences between people or groups due to social, geographical, biological or other factors. So there are things that we can do something about. They have a really significant impact. They result in people who are worst off, not only experiencing shorter lives, but worse lives too. There's a very clear social gradient around health inequalities. So the more deprivation you live in, the more you are affected by it. And we see that demonstrated in the life expectancy at birth by deprivation decile. So if you are living in our most deprived decile, you can expect to live 8.6 years less than a man living in our least deprived decile, and an 8.4 year gap for women. And in recent years, the gap for women has been increasing, but avoidable is the most important word that we take from that slide. So how can we make a difference? So I'm going to have to refer to my printout, because just as I left the office, I poured a cup of tea into my laptop. So it's all going ever so well. So how do we overcome the challenges? And so when I'm talking you through the data, if you can kind of bear these bullet points in mind, because this is about not just how do we describe the problem, this is what do we do in response to the problem. So how do we overcome those challenges? What does action look like? So we have to consider equity in all of our activities, and there is a difference between equality and equity, and we need to be purposeful in how we approach equity. So we need to recognise that a shorter person needs a taller box to stand on to reach the same height as a taller person, and we need to be purposeful in giving that shorter person the bigger box. I've got a better slide in a bit, but I think that's a really important point. We have to take a life course approach. We have to recognise that this is a cumulative disadvantage, and babies born in our most deprived deciles will not just start life at a disadvantage. That disadvantage will accumulate through their lives, and we need to be proactively engaging with those families to tackle that issue. We need to take a proportionate to universalism approach, and that is just fancy public health talk for saying we need to do more in some communities than we do in others, because we recognise that some people need more help in order to reach the same outcomes than others. We cannot do any of this in isolation. So Anna can do marvellous work at CHFT, and I know that they do, and that inequalities are at the heart of what they as an organisation want to deliver. But you can't do it by yourself. And I can't do this by myself, and housing services can't do it by themselves. We have to work together, and we have to co-produce the solutions to these problems with our communities as well. We can't just do things to our communities. We have to co-produce those solutions. And I know that when my colleagues talk to you, they will be talking about the work that they do alongside the populations that they serve. We have to learn, we have to monitor, we have to evaluate, and we have to share the good practice. We have to notice when we're doing stuff right, and we have to amplify it. We have to try new things, and if they work, brilliant. If they don't, we stop doing it and we try something else. But we need to be braver. We need to stop doing the same things over and over again. I think it was Einstein's definition of insanity, wasn't it? That if you do the same thing over again and expect a different outcome, we need to stop doing that. And then when we find things that work, we need to aim to make that change sustainable. We need to take a long-term view of this work. This is a 100, 200, 300-year-old problem, and we need to find the sustainable solution and not just go, oh, we're going to do something for 5 minutes and then we'll change our minds and do something else. It needs to be sustainable. So when my colleagues talk about what they are doing in response to inequalities, you'll hear a flavour of all of those things. So this is Kirklees. You will all be very familiar with what Kirklees looks like on a map, and I don't think any of what I'm going to say to you about where our most significant pockets of deprivation exist will be a surprise to you. The darker blue, the areas on these maps, the more significant the areas of deprivation. So you can see very clearly they're centred around the population centres of Huddersfield and Dewsbury. What gets hidden in this map is the interward deprivation as well. So it's not that all of Huddersfield is in the worst 10%, it's that as an average. So this hides pockets of affluence and deprivation. But broadly speaking, that's what deprivation looks like across Kirklees. And it's no surprise that, you know, fuel poor is very present for us at the moment, and those households living in those areas of greatest deprivation are most likely to be experiencing fuel poverty. So they're living in cold homes, they're less likely to be able to afford good quality food, and all of those other things that we know come with poverty. That's just another way of describing the same problem, but I think it's quite stark when we realise that children living in poverty, 6.5% of children in Denby Dale as compared to 60% of children living in Dewsbury West, and you can absolutely see that gradient there. This, I think, is a really interesting slide. This shows you the differences in life expectancy by ward. So you can see men on the left-hand side, women on the right-hand side, and Home Valley South with high life expectancy down to Crosland Moor and Netherton at the bottom. You can see that the gradient for men is much smoother. Women is a very technical epidemiological term, but it's a bit wibblier, the line for women. So a slightly different picture across the genders. What I think is interesting is if you were to imagine a vertical line that runs down that shows you healthy life expectancy, but also the age at which people retire, you will see that in our more affluent areas, we've got people who are probably retiring in a reasonable state of health, and people in our more deprived areas retiring, well, either not retiring at all or retiring in a much poorer state of health. And that has some knock-on consequences for our VCSE colleagues as well, because we know that to have a vibrant our vibrant VCSE sector is not entirely, but quite significantly dependent on our retired population. Well, if you haven't got a retired, healthy population, it's quite difficult for our VCSE sector to be as vibrant as it perhaps might like to be. I'm going to have to speed up. So this is just looking at the different causes of death by deprivation, and again just emphasising that point of the difference in life expectancy by our most deprived quintiles. And then this is about how people feel about their health and well-being. You'll be familiar as a panel with the CLIC survey, the Currently Living in Kirklees survey that we most recently undertook in 2021. And this is what people are telling us. So people who live in our least deprived wards are more likely to report their physical and mental health as good than those living in our most deprived wards. They're more likely to report being confident in managing their health. I'm going to flick through some of these, but you've got these in your pack. Smoking status continues to be a really significant marker of poor health for our population. You are significantly more likely to smoke if you live in our most deprived populations. You're significantly more likely to start smoking if both of your parents smoke as well. You're 3 times more likely to start smoking if your parents smoke than if they don't. And we know that smoking is really bad for you and has poor impact on people's health and well-being. You can see there as well that smokers by occupational group, the never worked and the long-term unemployed, much more likely to smoke than our managerial and professional groups. I'm going to flick through some of these. Okay, so this is a much more attractive description of my "you need to stand short of people on a taller box" description. So this is where we really get to the nub of understanding the difference between equality and equity, and our providers needing to orientate how their services are delivered to be in recognition of this. This is taken from our most recently refreshed Kirklees Health and Wellbeing strategy. If you haven't already read it, I recommend it to you. It's a good read, and it sets all of the work that we need to do with and alongside the population of Kirklees to tackle their health and well-being. But if you take nothing else from this, the difference between equality and equity, I think, is a really important point. So, slightly out of breath. I said I was going to rattle through. So I'm going to pass over to Anna. You've got a few slides now, haven't you, to talk about CHFT's response. And then I'm going to pass to each colleague in turn, and then we will have a discussion. Would you like me to move the slides on for you, or I will do that for you?
Hello, as I said, my name's Anna Basford. I'm Deputy Chief Executive and Director of Transformation at Calderdale and Huddersfield Foundation Trust. I've got a handful of slides just to bring to life some of the action we've been taking to address inequalities for our local population. So this first slide is just really a statement around our commitment as an organisation to address inequalities as a vital function that we undertake. We've recently refreshed our strategy for the period 2022 to 24, and what I've highlighted there is that the strategy focuses around 4 key areas, and I'm going to just talk to each of those. The 4 areas about the actions that we can take to work with local partner organisations and local people to address and reduce inequalities. The second area is about how we can improve access to services and equitable access to services. The third area is about how we can improve the experience of care for people when they come into services and need services. And the fourth area is about how we support our workforce and absolutely grow and support a diverse and inclusive workforce. So if I just go to the first of those areas, which is about how we've been working with our communities and partners. If you could move the slide on, please. Thank you. And I just wanted to highlight, just to bring it to life for you, some of the things that we've done here. So one of the first areas is that we've been working actively with local GP practices to look at where there may be inequality in the rates at which people are needing to access hospital services for conditions that might otherwise have been able to be supported with care closer to home. And we identified an inequality, for example, in the rate of access for people with asthma and respiratory conditions. And then working with the practice and with local people, we've undertaken work to provide advice and education, work with local mosques, to really look at how we can better support people around the management of their own condition. The second area that highlighted there is how we've invested into additional support within our accident and emergency departments, that we know that some people who attend our accident and emergency departments have wide-ranging needs beyond the hospital, and we may be a first point of contact for them, to enable us to be able to actually respond to that and connect them with the support they need out of hospital. They don't need hospital services, but they may have complex needs that do need to be addressed. We've invested in additional workforce, which is highlighted on that slide, to do that work and reach out into the community. I've also highlighted there that we recognise that we are one of the largest employers. We have significant public monies to invest, and the way we invest our monies and our public resources, we can do that with purpose to address and reduce inequalities, for example, through job creation for people who have been long-term unemployed within certain communities. So that's another example. So if we move to the next slide, that's area 1 of our strategy. The second area is directly what can we do to ensure there isn't an inequality in people waiting for services. We undertook significant work during the pandemic to analyse our waiting lists, and we did find there was a differential in waiting time for people with the same clinical needs. We found that people living in the greatest areas of deprivation or from Black, Asian, minority ethnic communities were waiting longer on average. What we did is take immediate action to reduce and eliminate that differential gap. We eliminated a gap of approximately 7 weeks, longer waiting time at that period, but we've also embedded that work so that we proactively use our understanding and analysis of the waiting list to make sure that that gap doesn't re-emerge. And that's been very targeted work. Linked with that, we've specifically done a lot of work for people with learning disability about how we support their access into hospital by establishing support in particular clinics, or if they do need to come into hospital for operations, how we do that effectively. And again, we've done a lot of work around the different ways that people can access outpatient appointments, really looking at reasonable adjustments and support around other languages, and that's highlighted on this slide. I'll just go to the third area in the next slide, please. Highlighted our strategy is really focused for when people come into services and they do need services, that we are making sure that those services really respond to their needs and address any inequalities. We recognise there is an inequality in outcomes of care for people who in maternity care and life expectancy, so we've done particularly targeted work which has been informed by working with local women around their needs, around putting on additional forms of antenatal support, and that's highlighted on this slide here as well. And I know there's been quite a lot of interest in our maternity services, and there's a strong story to tell around how that is also associated with targeting reduction in inequalities. And then the final area, in our strategy is the important work that we do to support our local workforce. We employ in excess of 6,000 people, and we're very committed to make sure that we are a diverse and inclusive workforce through our policies, through our proactive recruitment approach, and also by listening to colleagues. We have a range of inclusive networks within the organisation, and that we actively listen to people's stories and experiences of working in the trust and take action where we need to make improvements. I'm very conscious of time this afternoon, so that's a quick run through of some of the work that we've been undertaking. Thank you.
Thank you ever so much, Anna. We're going to pass now to Carol McKenna, who's going to talk about the work that the ICB in Kirklees have done. Carol, are you all right to bob your camera on and take over?
My camera is on, so I hope people can see me. Apologies, I'm not actually in the room today. I'm not actually talking about, sorry, just for those that don't know me, I'm Carol McKenna. I'm the place lead for the Kirklees Health and Care Partnership. We're part of the West Yorkshire Health and Care Partnership. So I'm actually not going to talk about the broader work of the partnership today. I'm here to give a bit of perspective on behalf of our colleagues in general practice, if that's okay. So that just going to take through a few slides focusing on the work that was done predominantly in the time of the previous CCG in relation to this. However, just wanted to start with setting a little bit of context, which is to remind people of the Fuller stock take, which was published last year, and sets out some good, I think, context and reminders for us in relation to health inequalities and the role and impact that general practice can have in this area. So I'll take us straight to the bottom bullet point on the slide if I can, because the stock take identified 3 areas where primary care has taken a more active role in creating healthy communities and reducing the incidence of ill health. And I think I just wanted to draw our attention to them because I think we are quite well cited on this in Kirklees. Working with communities, the panel, I think it was at your last meeting where you had the conversation about the development of neighbourhood working, and you heard there about some of the focus that's happening through our primary care networks, working with colleagues in community to really build an appropriate service approach in our neighbourhoods. The more effective use of data, and I'll say a little bit about that in a second, and through continuing to build close working relationships with local authorities, which I think in Kirklees we've always had. However, that's been strengthened in recent months by the allocation of elected members to each of our primary care networks, which again is a strong signal, I think, about our commitment to that partnership working with health equalities in mind. So if we just move on, please. So just a couple of specifics then I wanted to talk about. So what's happened in Kirklees in relation to helping general practice address health inequalities? So first of all, we have had for the last couple of years something in our local contract called Kirklees Essentials, which asks all practices to consider the needs of patients from a variety of backgrounds, such as those listed there. So that applies across the board to all 64 practices. However, in addition, we introduced a health and equality scheme for general practice that was introduced 2021. I was going to say last year, but it's coming up for 2 years now. And that scheme supports the 15 practices with the highest level of deprivation and those with the highest percentage of Black and minority ethnic population. For those practices, they meet as a network 4 times a year, and that's chaired by one of our independent GPs, one of our independent medical advisors. And the network's also attended by the local authority public health team through Emily, I think, actually, as a colleague who's on that. So as part of that network, the practices involved share good practice, solutions to challenging areas, and listen to external speakers who can focus on a range of issues. And examples of the sessions have looked at topics such as dementia diagnosis, Core 20+5, cervical screening, cancer screening, and a variety of other topics. If I can just move on, sorry. Thank you. So each of the practices that's part of this scheme receives a limited amount of additional funding, which links to our Core 20+5 approach in Kirklees. And each of the practices was required to identify 3 priority areas which aim to address health inequalities and improve quality of healthcare. And there's some examples listed there of the work that individual practices have been doing, which I'm conscious of time, but I won't read out. But there's just some examples in. You can see at the bottom the reference to the work around asthma, which Anna has already talked about. And then if I can just highlight the work that's happening actually through primary care networks. So what I've spoken about so far is related to individual practices. There's also an approach around tackling neighbourhood inequalities that's managed through the PCNs. So as you know, each of the 64 practices in Kirklees is part of a primary care network, and they have to deliver the PCN directed enhanced service, which is connected to the national contract for general practice. One of the national service specifications for this financial year is focused on tackling neighbourhood health inequalities, and there's a list of requirements there which each PCN is required to do. And again, I won't read them out. You can see them for yourself. But just to reference back to that earlier point about the importance of data, our PCN data packs produced by colleagues in the council have recently been refreshed to sort of council and across the partnership. Have recently been refreshed to assist with that work, and there's a connection there for you to see that. But that data is something that our PCNs have found really helpful in terms of helping them really understand the needs of their population. So it's great that they've been updated so recently. And then I think I might just have one final slide. No, I've got 2, sorry, just quickly. So again, some examples of the sort of projects that PCNs have undertaken on the back of this directed enhanced service. And again, won't read them out because we're there and people might want to ask something about them when we get onto the conversation. But that's the sort of projects that the PCNs are working on. And the clinical directors from the primary care networks come together with us every month, and we have a fairly regular update in that meeting about the work that they're doing, and there's some real sharing of good practice there. And then the final example, just to draw your attention to, is obviously, as you're all aware, the COVID vaccination programme has been a big part of our lives for the last couple of years. And there's numerous examples of how our PCNs and general practices have worked together with colleagues such as our community champions in the voluntary and community sector, faith organisations, to reach patients from backgrounds where the uptake of the vaccination has been considerably lower. And we've heard examples of pop-up clinics in mosques and asylum seekers, for example, in support of that. So I think that's my slot. I'm not sure if you're passing on to
Thank you ever so much, Carol. We're passing on to Sean next.
Yeah, thanks, Emily. Good afternoon, Sean Rayner from South West Yorkshire Partnerships Foundation Trust. We provide specialist mental health services and services to support people with learning disabilities, and provide autism assessment diagnosis as well within Kirklees. So our trust board takes an approach where in every aspect of our work, whether through that's our service provision, our governance in the organisation, health inequalities is embedded in our approach, and also in terms of the way we go about our governance. We expect every service development, every service plan or any change we undertake within the trust to be backed up by an equality impact assessment and a quality impact assessment, and that's just the norm, and it has been for some time now. The approach we take is one where we ensure, or try to ensure, our services are provided with the best available evidence and data in order for them to provide their services in a way which as best possible addresses health inequalities, and the Trust Board itself receives feedback on the impact of the work that our services and teams undertake within the community. So thanks Emily, if you can move on to the next slide. That's why we've made it a priority to ensure that we capture the best available data and evidence in order to understand our services, and that's just not the data that's available through Emily's team and the published data elsewhere, but the information that we capture through our service provision and directly with our service users. And in that context, if you go on to the next slide, please, we had a campaign called All of You, aimed at both our staff and people who access our services, and that was specifically designed to improve the quality of our equality data, particularly for people who use our services, because we're very conscious that it wasn't as good as it should be, and we're still improving that all the time, but it's a lot better than it was, and we're now using that in terms of the feedback that services use that data themselves to adjust their service provision accordingly. Thanks, Emily. So in that context, all our services now have access to an inequality dashboard in line with the Core 20+5 parameters, and that breaks down data metrics where they can understand the impact they're having and the service reach they're having in terms of ethnicity and the deprivation of their service population. Thanks, Emily. So the final couple of slides just give a summary of some of the examples in Kirklees of the work we are taking now to try and address health inequalities. And we're very conscious as an organisation that West Yorkshire Integrated Care System has a strategic ambition to ensure there's a 10% reduction, 10% reduction in the gap in life expectancy between people with mental health, learning disabilities and/or autism and the rest of the population. And as a provider of services to support those people in the community, we feel we need to take a central role in advocating for those people, but B, ensuring our services are doing something about addressing that gap in life expectation. So that's just a brief summary. Thank you very much.
That's really helpful, Sean. Thank you. It was always an ambitious amount of stuff that we were going to cram into this presentation. So Andy is last, and he's going to be brief.
Yeah, thank you.
Thank you ever so much.
That's okay. Thank you very much. So Andy Petrie, I'm Chair of Third Sector Leaders Kirklees and Chief Executive of Local Services to you. To be honest, I can be fairly brief because I think what's been interesting through some of the other presentations is the reference to the voluntary and community sector throughout there as a partner and there's a number of examples that have been referred to already. And the sector is a key partner in addressing health inequalities, and those relationships and structures are developing at different levels at West Yorkshire, Kirklees and neighbourhood, and have been for some time. And there continues to be progress around shared understanding. I've said there's still work to do, and I think some of that's around language. A walking group, for example, a local walking group would describe themselves as a walking group, but they wouldn't describe themselves as a diabetes prevention initiative, but they are as well. And so I think sometimes it's that language, when we get that shared language, we recognise the connections are even stronger. And I think some of that has come through recently with the social prescribing work, the primary care networks, and the links to local community activity that we've seen. Trying to capture the variety of work within the sector is an impossible task. You've got very small grassroots organisations to providers that operate services across the whole of Kirklees and wider. So it is a very diverse picture. Resources are a challenge for everyone. heard before about the inequalities within communities and that capacity within communities where there are health inequalities that can sometimes impact on the ability of that community to respond, particularly within the voluntary and community sector. So you have that compounding effect in some cases. So in terms of the approach, I'll just go through this quickly. I think one of the important things about the voluntary and community sector is the approach it takes, what it brings. It's holistic, it's personalised, community-based. There's a lot of importance around relationship trust and building trust over a long period of time. And it can respond to local needs and respond very quickly. It can work at a very, very local level, identifying geographically very local needs or within particular communities or around particular health conditions and respond to those quickly. And it can engage with parts of the population that other agencies may have challenges working with sometimes, and it often brings shared lived experience to the development of services and the development of solutions that are effective and really meet the needs of those communities. So, as I said before, there's been some examples already. There's a really wide range of what the sector can do, from preventative to delivering services to recovery support. It can provide those opportunities for social connections, so that reduction of isolation, through all sorts of local stay and play activity, arts and creative. It can help people get active, help people access services. We've had examples of the community champions that were working alongside services, bringing people, trying to address some of the misinformation around COVID and encouraging people to access services. And then that crisis response. So COVID was a good example of lots of mutual aid, but more recently you've got organisations providing food, support, warm spaces for those that are struggling with the cost of living crisis. There are lots of examples of case studies. I've included a couple of links there, but you've got organisations locally that there's Eat Well, Move More, that's a community-based programme that combats obesity and diabetes, offers healthy eating, cooking classes and exercise. And so those activities, as well as being part of a group and feeling ownership and developing those friendships, are a really powerful way of engaging people in activities and bringing that sense of purpose to overcome challenges that may not have been addressed through other programmes as well. I could give lots more examples, but I won't. I'll leave some time for questions, so thank you very much.
Thank you so much, everybody. What a lovely group to be part of to tell about our work. So apologies for overrunning slightly, Councillor Ramsey, but we had been slightly over-optimistic, I think, in terms of what we were going to fit in, but that's the end of our presentation.
I'm sure we all valued it. Yeah, very enjoyable. Some really nice areas that you touched. We're going to be quite traditional and go to the panel for questions. And then I'll pick up any questions that they haven't asked that I've written down. No, I'm joking. No, I'm not. And then we'll move on. I'd like us just to have about half an hour on here, so about 10 past 3. Okay, we're aiming for, if that's okay. The other thing that I should warn you is that we're expecting a fire alarm test, and we will have to take a short break when that is actually happening. So I'm sorry about that. So, Bill, can I start with you? Should we work down there? Excellent. Alison?
Hello. I'd just like to, this is a question for Anna Basford. I'm just trying to understand the causes of inequalities with the waiting lists. First of all, were they waiting to see a GP, or were they trying to access a GP? Are they waiting for a referral? Are they waiting to see a consultant? And I just wondered, was it due to perhaps the fact that they didn't understand the information they were being given, or did they need a translator to help people understand what was going on? Are those some of the problems? And then just following on from that, so presumably part of the solution is to relieve the pressure on the NHS. So in relation to access and prioritisation. So can you tell me what is being done to reduce that pressure? Because that really underpins any plans. And there has been talk recently this week, the Church of England wading in about a total rethink of adult health and social care, because that presumably is also part of the problem as well, and that really needs to be resolved. So if you could just give me some feedback on that, please. Thank you.
Thank you very much for that. I'll answer your first question, which was about, as I understand it, what was the reason why people were waiting longer to be treated and who were those patients? The analysis that we undertook, this was for patients who had already been referred into our services and had been placed on a waiting list to receive treatment or operation. And during the pandemic, we used a way of looking at people's clinical needs, because as you would expect, we treat people with the highest level of clinical urgency in that order. So it's you treat people based on their urgency of clinical need. But what we did is we used the data we hold on our electronic patient record to look at, for those people who were considered to be in the same category of clinical need, was there a differential dependent upon their place of residence within the index of multiple deprivation or in relation to their ethnicity. And what we found is that there was. What we don't know is the reason why there was that differential. We took the decision during the pandemic that we could spend a long time trying to understand the reason why that differential had arisen. But actually what was most important was to take immediate action to eliminate that differential waiting time and ensure people came into treatment and were not waiting longer than others with the same clinical need. And that's the work that we've done, and that's the work that we've embedded to ensure that that differential does not arise in the future. So, you know, there are lots of reasons people might surmise could be causal factors for that differential, but we absolutely don't know the absolute cause of that. But what we do know is that it's not acceptable, that there's that differential waiting time, and that we've taken action and embedded that action in a way using our quite rich data sources that we have through our electronic patient record. We actively monitor waiting times relevant to those indices around the index of multiple deprivation and ethnicity to ensure it doesn't arise again.
All right, thank you. I mean, it's just that if you don't really know what the causes were, you may not be addressing it fully. That's, you know, and it could possibly, but obviously you're doing everything you can to address it, but if you don't know what the cause was, it's a bit difficult, isn't it, really? Yeah.
I think it's the million-dollar question, is what's the cause? And there is work being done nationally. The King's Fund are looking nationally at what are the causes of those differential delays. There's nothing to suggest that what happens in the Kirklees population would be any different to what's happening nationally. So we await that report with interest. I think it's worth just commenting on the work around primary prevention and improving access as well, because as Anna says, the patients that CHFT are responding to are those patients that have been referred to you. So there's lots of really important work that we do with our communities. If we pick screening as a particular issue, we know that we have lower uptake of screening, whether it's cervical or breast or bowel or any other screening programme. I shouldn't have started naming them, should I? We know that the uptake of screening is less in our more deprived populations, which means that the risk of presenting at a later stage of disease and therefore with a reduced chance of complete recovery is higher in our more deprived populations. So that work that Carol described with our GP practices and encouraging uptake of screening is really important, because I need to get people in a better state of health to the specialists that Anna works with in order that their health outcomes are better, which is why we have to do this in partnership.
Thank you. Sorry, could you just answer the question in relation to solution part of it being the NHS and relieving the pressure on the NHS? Thanks.
Thank you for that question. It's a very broad question, and I'm struggling to think about the focus of the response to that, because I think the question is, there is a very high level of demand on the NHS and on our social care services. There's a range of actions that are being taken around the developments that are being supported, so that people don't need to come into hospital, they can access services and support in their local communities. The work such as we've heard about, working with voluntary sector, but I don't think there is a neat response to what's the solution to reduce demand into the NHS and on our social care services. It's a significant challenge that we're particularly living through in these winter months at the moment. I think some of that is very much about it needs to be solutions that are found in partnership with our local community. So I'm not trying to avoid the question. I just think it's not a...
Yeah, it's a difficult one, I think. It's broad,
maybe that with permission of the chair, other colleagues on the call may have perspectives on that.
And I think this is why it's really important that we have people like Andy with us today, because the role of the VCSE cannot be underestimated in responding to this. So Anna might have a elderly gentleman who lives alone, who is medically fit for discharge, but he's being discharged to a house where he lives alone. It's a cold house. He doesn't have the skills to cook for himself on a regular basis. We know that food and nutrition is absolutely vital to people's recovery. That's where it's so important that the role of our VCSE colleagues to support, because he doesn't need a service, he needs people who can wrap around him and look after him and make sure that he's got a warm home. And it's sometimes a solution is as simple as the things that we're doing within our 24 libraries and the warm spaces. Each of our warm space libraries now have a stock of clothing and hot water bottles and those sorts of things, because the worst thing we can do for a medically fit person is discharge them into a cold home that doesn't maintain their health and well-being, because you'll just see them again.
Thanks. Thank you.
Thank you. Leslie? Yes, thanks. Hi. I think a lot of what the new initiatives are quite impressive. And I think in Colne Valley, we've been particularly fortunate that you set up a drop-in centre. It was last year. But one of the things I just want to raise that seems to be a thing I've been banging on about ever since I became a councillor. Luckily, being a governor and also on here, I get to find out quite a lot. I'm still trying to process it after 3.5 years because it's complicated. But just as an example, when that drop-in centre was launched, there were 15 or so of all the different prescribers and everything for the valley. It was fantastic, loads of them. There was no doctors, which is what it was aimed at, and there weren't many of the public. I mean, I ended up going down the local food bank. It happened to be a food bank day, and loads of them came up and were really pleased and got questions. So to me, there was an issue about publicity. Subsequently, as part of Colne Valley Health, which was the mutual aids, which now covers the Colne Valley, we've been contacted recently by 2 different doctors at absolutely wit's end about needing support and help, and didn't seem to be aware of the range of things that are available. And I think you may be aware, sort of, one of the people on the Colne Valley Health, and Councillor Elizabeth Reynolds, they put together a basic bullet point thing. Now, as far as I was concerned, Gemma Atkinson had done a lot on this, and it was out there. But my question really is there enough communication of the good things that are going on in the places where it's needed? I mean, I get quite a few phone calls about needing help, and I'm able to signpost some of them, not all, but I just have a sense that you're doing a lot of good things that not everybody is aware of.
I am aware of the issue that you raised, because I spoke to Councillor Reynolds at some length about it. You're right, there is some really good work going on, and I think we do a reasonable job of communicating about it. We could do more, of course we could, and we're really trying hard to do that. I think the role of the community champions is going to be key in that as well, because at the risk of sounding like a lager advert, they are going to be able to reach parts of our communities that we cannot, and that is the the point of the community champions role, because we know that we can get messages so far, but actually it's your next door neighbour, it's the person over the road saying, do you know about, have you tried? So I think it's not necessarily what messages we give, it's how we give them. And I think the opportunity of the community champions helps with that. I think the social prescribing link workers are really key, because this is a complex system that we are trying to navigate, and the more that we can have people who are able to walk alongside people and help them navigate it, the better. So I think the comms is okay. It could be better, but that's about us working with our communities so that they understand what they've got and that they can tell other people about it. It can't just be me turning up going, well, I'm a consultant in public health and I think you should do this. It's terribly good for you. That's not going to have the impact that we need it to have.
Can I just ask, for example, I was contacted by, it's just one of these people at home, Alzheimer's, needing desperate support, all sorts of issues. So I immediately went to Near, because Near Atkinson happens to be our local. But it turns out that they live just out of, they're in Cone Valley, but they were in Longwood. So she was only allowed to work in Slowett and Marsden. So is that quite a rigid demarcation?
I don't know, I'm afraid. It's not a service that I'm familiar with.
It just felt a bit like, but she would be happy to work with them. But when I said they were in Longwood and not Cone Valley, she said, oh no, you need to contact somewhere else. And I just didn't know how rigid the demarcation was.
I don't know. One of the things that we have been doing over the last couple of years is working in a systems leadership space. So increasingly we move people away from going, well, my job says I can do, and the lanyard around my neck means I work towards, more into a space of working with and staying alongside somebody on their journey. So I would hope that we are moving away from, well, your postcode's that, so I can't. But I can't comment on that specific service, I'm sorry.
Excuse me, with permission, Chair, could I just clarify which service it is? Because if it's a service of the Trust, I will take that away. But I was unclear if you were referring, what service you were referring to.
No, it was just somebody needing a lot of support, and they're being passed through all sorts of things and not getting it. And so I then contacted Near, who said that because they lived in Longwood, they couldn't be dealt with by her. As it happened, she gave me the name of someone else, and I was able to contact them, and they were in touch. But I was looking at how clear these boundaries are, that was all.
And I'm sorry, is Near... I'm sorry.
Near Watkinson is one of our social prescribers.
Sorry, I wasn't sure whether Near was a person or an organisation.
No, sorry, Near Watkinson is a social prescriber in Cone Valley.
Thank you.
Comes to our community cafes and stuff like that.
Well,
she's very good.
I'm happy for my question to, I'll ask it, but then we can come back to it in another form if you want. Just basically of the actions that everybody's taking, of those actions, which of those have proven to reduce health inequalities, and are we sort of measuring that and getting the proof of that? And also, just what's the biggest one to tackle that is difficult for all to manage, the biggest challenge? And also, just a quick question about the wellbeing service, the Kirklees wellbeing service, where that fits in with that. So I'm happy if that's not a quick answer. Okay.
Shall I make a start and then other people join in when you know the words? So the Kirklees Wellbeing Service, I'll take your questions in reverse order if that's okay. So the Wellbeing Service it's a public health commission, so we commission it, and it's funded through the Public Health Ring Fence Grant. It's an internal commission from the council. The routes of referral into the wellbeing service are either a health professional can say, I think you would benefit from, or individuals can refer themselves. Refer isn't quite the right word because that over-medicalises the model, but that's about the routes of access. The wellbeing service is very holistic in its nature, so it will provide different support to the individual depending on what the need is. So if the individual presents and is very clear to say, I want to stop smoking, then they will provide a smoking cessation service. If the individual is less clear that I'm just struggling with self-esteem and emotional health and well-being, then they will take a different approach. But it is a free point of access, self-referral or professionally referred service for the population of Kirklees.
And so is that integrated and included in
Yeah, it's part of the resource that is available for the population of Kirklees. So some people will access it having been through their GP, and their GP might say the wellness service is something, or somebody might know that wellness service is available and they will access it themselves. But it's definitely part of the suite of services that we have for the population of Kirklees. Your other two questions, the biggest issue to tackle from my point of view is poverty, because poverty is at the root of all of the inequalities. So we're talking specifically today about health inequalities, but actually in order to impact on health inequalities, we have to impact on inequalities more broadly. So we know that people who live in our most deprived deciles are more likely to live in poor quality housing, they're less likely to be well insulated, they're less likely to be able to afford to heat their houses, they're less likely to be able to have access to good, healthy diets. We hear things from the food banks about the increasing number of people who are in work but requiring the food banks. We hear from the food banks that people are specifically asking for food that they do not need to heat because they cannot afford to heat their food. So for me, poverty is absolutely the thing that we have to respond to. Part of how we're doing that is working with our colleagues in the Welfare and Exchequer Service to ensure that people in Kirklees who are entitled to benefits are maximising the amount of money that they are able to access. Part of that is through our Exchequer Service, as I said. Part of how we're investing the Core 20+5 money is in additional welfare support advice that can be cited within primary care, so that we can maximise the opportunities that people have for the amount of money that they have in their pockets. So that would be my pick for the thing that we absolutely need to, but colleagues may have alternative. Sean looks like he...
Yeah, it's a really good question, and I think one of the things I would highlight is the health checks for people with severe mental illness or people with learning disabilities, and that's a national initiative, but it was introduced relatively recently, and is designed to ensure that those groups of the population have annual health checks organised through their general practice. But we in Kirklees we support through providing mental health practitioners to ensure people with severe mental illness have those health checks. But it's not just having the checks themselves; it's making sure we follow through on any issues. That's the value of them. And if you recall, I spoke about that 10% reduction in life expectancy of people with severe mental illness and/or learning disabilities, and that's probably one of the key actions we can take as a health and care community to address that, because we can then address things at early stage rather than at the acute crisis stage. So I think those health checks are really important, I would suggest.
And actually, that's a really lovely segue into what I was going to give as my answer to what are the things that are proven to reduce health inequalities. I think the health checks is really key. But as Sean says, it's not just the people having the health check, it's the so what? It's not just saying, well, your cholesterol's a bit high or your blood pressure's a bit high or you could really do with losing a few pounds. It's the proactive follow-up. I also think other things that are proven to reduce health inequalities, access to screening. I've already made reference to access to cervical screening, breast screening, bowel screening. We've had some really good success in targeting increasing uptake of bowel screening in Kirklees in our they're not harder to reach populations at all. They're just, our services are difficult for them to engage with, but in our more deprived communities. So I would say, in terms of the biggest thing to tackle for me is poverty. The things that have been proven to reduce health inequalities are screening, vaccination, and access to health checks with proactive follow-up.
Sorry, because everybody said actions and achievements, and I just wondered, obviously just a selection on the report, just are those routinely sort of checked against the evidence that, has it reduced and by how much, and, those sort of things? Is that common practice?
Yeah. So within the health checks, as an example, we've run a pilot for the last period of time, can't remember the specific period of time we ran the pilot for, where we ran the health checks through the wellness service that you made reference to, because we know that for some of our populations, accessing the wellness service is an easier route for them than accessing primary care. So we piloted a different way of delivering the health check, and we know that meant that we increased the uptake in some of our populations that perhaps didn't have the uptake as we'd like. But we routinely keep an eye on the data that is recorded through the FOF, the Public Health Outcomes Framework. It's available in the public domain if you wanted to have a look. And there's a whole range of things that are measured around things like school readiness, uptake of vaccination, smoking rates, drug and alcohol use, all of those sorts of things. So we routinely keep an eye on where we are in.
So those health checks, you said it was a pilot.
Yeah.
And and it worked. Is that going to continue?
So we are just in the process. In fact, the meeting is on Monday with the University of Huddersfield, who've undertaken the evaluation for us. We'll get the results of the evaluation in the next few weeks, and then on the basis of that evaluation we will design and redesign the approach that we take to health checks. So without having seen the results of the evaluation, I don't really want to comment on that anymore, but it's just an example to give you of we've tried a thing, we've evaluated it, we'll see what difference it made, and then we'll do something the same or different on the back of that evaluation.
Yeah, that would be interesting to know what that evaluation is and what your decisions are afterwards at some point.
I'm happy to.
Okay. Thank you.
Happy to come back.
Okay, I'm just going to guide us on. Kim?
Hi, my question is around communities that don't typically access traditional healthcare or for services aren't necessarily available to them. And you mentioned food banks, and my experience of doing a little bit of work with a welcome centre is a significant population that are in temporary accommodation, that might be in hotels that certainly don't have access to cooking facilities, gypsy and traveller communities, people that are homeless. So what kind of services are in place for those people? Because I might be making an incorrect judgment, but I would think that those people that are really struggling to keep warm and eat would not likely to be accessed screening care, because that might be something that will be quite low down on their priorities. I might be wrong, I might be making a judgment, but I'd just be interested to hear what services are available and how you target those kind of communities.
Yeah, shall I start? I mean, I think that those particular communities are where there is often a voluntary community sector response to some of that particular initiatives, and they can be very local or they can be wider. And if you've had experience of a food bank, you'll know that often someone might present there in crisis needing food, but actually there's a whole lot of other things going on as well behind that, and often their circumstances can be complex and complicated and cover housing, health and so on. And that food bank or that community organisation or whoever have got that trusted relationship with that person and are well placed to provide advice. Now, they can't solve everything and anything there. I think it's then how we equip those organisations with the knowledge around where to go, where to help people, not just signpost people, but take people along, support them to the other services. And I think that's a real challenge. You know, that can be a real challenge for small food banks to set up, trying to understand and navigate that landscape. I think that's where we're making good progress around some of that locally, though. The community anchor organisations that are working alongside primary care networks and with community champions will often have a knowledge of what services are out there or where to take people or signpost people to. So there's that element of, once they're engaging with particular populations, understanding how to help them. I think also it's about having screening assessments in accessible locations, so places, community centres, that if people are not comfortable accessing healthcare settings, coming out to those, taking them out there to put services on there. And you've seen that, you know, the pop-up clinics that were referred to before in places like mosques. So you can have a bit of preparatory work with the people in the organisation so that they can have those conversations. We've seen it around conversations around immunisation. For my organisation, we work with a lot of young parents, and during COVID, getting childhood immunisations was a real challenge. We work in communities where there's particularly low rates as well. And one of the issues at that time for that particular cohort was they had to go by themselves, and normally they might take a parent with them or a family member with them as well. And so it's then, how can we, if we understand that, if we understand what the issue is, how can we design a response to respond to that? So can we do it in another location where there might be peer support around?
Carol, I wonder if it might just be worth saying a couple of things about the White House and the specialist primary care services that are delivered through there.
Yeah, absolutely. I mean, the White House practice has been in Kirklees for many years. I think it might have been, it's probably about 20 years actually, because I remember it from quite early on the days in Kirklees. So like you say, that's a specialist primary care service that delivers services to, for example, asylum seekers or people who are homeless, and where possible enables them to then move on into another practice. But that's a long established service that operates in the centre of Huddersfield for some of the population groups that we've been talking about, and they continue to work closely with the council, Emily, don't they, when we know, for example, we might have resettlement programmes or anything happening. We make sure that we've got the White House actively involved in those discussions.
Thank you.
There's one screen I can see.
Hi Liz, do you want to go? Councillor Smage?
Yeah, thank you. Just couldn't get the button pressed. Social prescribers, Emily, you mentioned about the importance of social prescribers, but have we done any work on equality of access to social prescribing? Because people do not necessarily know who they are, how to access and what they do. So do we know that across Kirklees people have access? There is equality of access. And you also mentioned about poverty. We used to have a Tackling Poverty in Kirklees strategy and action plan. Do we know how that work is being tackled at this moment in time? Because that Tackling Poverty in Kirklees action plan ran out in 2018. Thank you.
So the Tackling Poverty question, Councillor Smage, we currently have a poverty partnership, poverty network that runs across Kirklees. You would be very welcome to be part of it, and I will make sure that my colleague Tom, who manages that network, sends you the information. It's very intentionally kept as a network rather than a board, because the last thing anybody needs is to go to yet another board meeting. But what we increasingly know is that people need the space to come together with other people who feel passionately about the things that they feel passionately about and do something about it. So that's our approach to tackling poverty. And I'm even writing it down. Tom, send to Councillor Smage. So that will be winging its way to your inbox later on this afternoon, Councillor Smage. In terms of the equality of access to social prescribing, it's very much about the primary care network taking their own individual response. So while we as the local authority have a role in kind of oversight and overseeing the social prescribing link workers, I think that's down to the individual primary care networks and how they make use of them. What I can say is that I increasingly hear from GPs about the real benefits that they see of having social prescribing link workers attached to their practices. And we had a lovely story, didn't we, Carol, at the ICB committee a week or so ago, where a GP, who I think it would be fair to say had been previously fairly traditional medical model in his approach, was talking very positively about the huge benefits that he saw of having a social prescribing link worker, somebody who knows the system and can navigate it, and the benefits that has to his practice. In terms of the equality of access, I don't think we ever have done that very specific piece of work, but I am confident that each of the 9 primary care networks sees the value and is working to deliver social prescribing in a way that suits them.
Lizzie, you wanting to come back in? Are we able to move on?
Yeah, I think it would be interesting to know if there is equal access to social prescribing across the whole of Kirklees. I think that would be interesting to understand that all GP practices are involved in that, and that people do know what they are, so they can actually ask to be put in touch with social prescribers.
It is, as ever, an excellent question, Councillor Smage. And the pedant in me wants to talk about the need for it to be equality of access, not equal access to social prescribing. But apologies for my slightly pedantic response.
I am going to move us on. Jo, do you have any questions you want to raise? I don't, because they're not been asked. Excellent. And Vivian, yourself?
Thanks for the last by Councillor Monroe and fairly adequate and full. The last bit I'd like to ask is, how are you measuring your success rate so far?
So that's an enormous question. There are a whole range of things that we measure in order to understand the progress that we're making, because I said earlier, we're not just talking about health inequalities here, we're talking about inequalities in its broadest sense. So if you think about those things that we need to measure across the life course, it's things like the proportion of children who are ready for school age 5 in Kirklees, so that emphasis on giving children the best start in life. It's measuring things like the number of people who are waiting for care, as Anna described. We have an outcomes framework that sits alongside the Kirklees Health and Wellbeing Strategy. And that outcome framework goes across the 8 outcomes for our Kirklees population. So that goes from children have the best start in life, people feel safe, access to clean, green environments. And then within that outcomes framework, we have some high-level outcomes that we measure that show us that we're going in the right direction. So they're things like women smoking in pregnancy, people who are babies being breastfed, and then we go down to some more service-specific things that we measure, and we routinely look at that data to show us whether we are going in the right direction. and we use those as proxy indicators for the progress that we're making. I would love to be able to sit here and go, if we could just measure these 3 things, and they would tell us whether we're solving this issue or not. But I can't do that, which is why we've had we've developed the outcomes framework that, as I say, sits alongside the health and wellbeing strategy, and will become a routine item for the health and wellbeing board. So those conversations will take place there.
Thank you. I think we're just going to move on, if that's okay, Vivian. Yeah? Obviously, because I've managed time like this, I haven't got as much time to ask all my questions.
Sorry,
so
that's
I'm just going to, so I will note, certainly life expectancy for people that are in the most deprived areas does seem to be reducing. So, you know, as an overall measure, at the moment,
if you're a man.
Poverty. Well, yes, but did you not say that for a female that if you do the comparison, the gap? And if you look at it from not only life expectancy, but from kind of like real health outcomes and from self-reported outcomes, you can see that. I thought you explained that really well. I thought it was really good that you talked about using postcodes or the deprived, the multiple deprivation index, and actually that is part of your waiting list management. And it'd be really interesting to see the King's Fund, obviously the graph that we've got, whether that graph does really reflect what's happening at CHFT, because you covered it off from a BAME perspective, but I thought that was really good, and I think you covered that from a SWIFT perspective as well. And so that message has got through about deprivation is where you live in and how much money you've actually got to spend. So you've done really well there, Emily, in getting that through. I couldn't not have a meeting and note that we're still unable to have a baby in Kirklees unless you have a home birth. You either have to have them in Wakefield or you have to have a baby in Calderdale. And so access to a birthing is still something that we were discussing, and obviously you said that we're having that debate, and there is an inequality of access there, and it will be interesting to look at the deprived wards within Kirklees and how access is working from a maternal and from an infant morbidity perspective there. So the stuff that we were talking about, Carol, around the PCNs and the work that's been done, and particularly I thought the 15 practices that you got together that from the most deprived wards, that sounds like there's some good work or some good learning in there. It would be really interesting for us to know what the ratio of resources for GP practices. Now, I know I would have asked in the past about how many patients per GP, but obviously we're looking at a wider practice group, and how wards that are really deprived, how are they supported, and do they have the same amount of primary care resource, if you like, invested in them, from a manpower point of view, rather than from a cost perspective. I think you're going to answer that. So.
I won't give you a complete answer, but shall I just make a couple of comments on it, if that's all right? So the way that GP practices are funded is there's 2 or 3 elements that build it up. So it's a national contract, as you know, primarily. Each GP practice gets funding through their global sum on the basis of £1 per head of registered patient. Over and above that, they are also funded for additional services that they provide through things like the Quality and Outcomes Framework. And that entails things like long-term condition reviews and a variety of other things. So that gets built up on top. Then in addition to that, there are also what we call local enhanced services that are things we commission locally, and things like the Kirklees Essentials that I referred to earlier as one of those local enhanced services, as is the Health and Equality Scheme. That is something we've chosen to do in Kirklees locally. So you could say that if you just look at the national funding, that all GPs are funded to the same level, because it's that £1 per head of registered population. However, obviously not all practices have the same level of are serving the same population group. So some practices quite reasonably argue, should have more to do the same, because the much higher levels of need within their population. And that's always the tricky bit, because no matter how you set a national formula for anything, there will always be some people who believe it's fair and some people who feel otherwise. So the reason we focused on our Kirklees Essentials work and our Health Inequalities scheme for those 15 practices in Kirklees was to try and, I don't know what the right word is, mitigate some of the challenges that exist within the national formula and recognise that some of those practices did need some additional support to be able to provide services to their population groups. I think then the question about how does the workforce look across neighbourhoods, PCNs, etc., etc. I think I've not got that to hand, so I wouldn't want to have a guess at an answer. But I think it's a very, very valid question. But some of the by funding things like the Kirklees Essentials element of the programme, one of the expectations would be that perhaps workforce needed to be put in to address some of the issues that were identified. So it's that bit of it is, I couldn't tell you offhand in terms of how it, how the workforce is spread in that way and how it corresponds with some of our more deprived communities.
Thank you, Carol. I thought you summed it up really nicely, and I think what's come out is that some of the things that GP practices do get paid for screening, vaccinations, things like that, are much harder in those more deprived areas, haven't got those income opportunities. It's harder work in those areas for some of the workforce that are in there, so they move, they go to areas. And I think that's across the board. I'll just carry on. I've only got one more thing, I think, that I think I need to pick up just from my questions, and that was from the voluntary sector. When you were talking about, I think it's on one of your slides, there's a bullet point that says that it's harder to provide voluntary sector community activities within those areas that are more deprived. And what would you want to help you to do that? How would you? But if you could sum it up in for 2 minutes, that'd be perfect.
I think this is part of. Emily talked about systems. It's part of recognising some of those challenges and then looking at how do we address them. If we've not got the capacity within some communities that have got real challenges, well, how do we deal with that now? To sort of address those pressing needs now, but how do we build capacity in those communities over the longer term, and having that longer term view about some of this, partnerships with the voluntary and community sector over the longer term. We know it's difficult for funding and resource arrangements for everybody, but I think what we know or what we recognise is that local solutions, local people having more control and power over their own lives and coming up with solutions often provides better solutions. So how do we, where there are gaps and particular issues, how do we plan for that over the longer term and build that?
Thank you very much. I think the point's been made really clearly. When you're in crisis, it's very difficult to then volunteer to do something, so I think that was made. I am going to draw that discussion to an end, Leslie. Thank you very much for coming to present. Obviously, we've enjoyed it. And I know that isn't the whole purpose, but we've enjoyed the discussion, we've enjoyed the debate, and I think you've come out with some stuff. It will help us as we have a look at the whole picture of health and social care this year. So much appreciated. We are going to take a very short break now, just before we set up for the next presentation. Hi everybody, thank you very much for allowing us to just have that quick turnover break. We'll go straight to Michael. I think you're going to present, aren't you? Will you introduce your panel as you do so?
Is that fine? Can we hear me now? Hi everyone, I'm Michael Crowther. I'm Chief Executive with the Kirkwood Support Life, which is the relatively new name for Kirkwood Hospice, the adult hospice provider in Kirklees. But it's not much of a panel. I've got a colleague, Helen Duke, who's Assistant Director of Operations at Locala Health and Wellbeing, so she's joining us online. And Locala are one of the almost like the core partners in what's called the Kirklees Palliative Care Partnership, which we'll talk to you a little bit more about. But first of all, just thank you for the opportunity for showcasing the work that we've been doing over the last few years. We're really proud of what we've got here in Kirklees from a couple of dimensions, really. One is that it may interest the committee to know that in Kirklees we've got the most comprehensive range of hospice services that are available to the local population than you can find anywhere else in West Yorkshire. And those services are reaching more people as a proportion of the population than anywhere else in West Yorkshire. And the approach that we've taken around this integrated approach since 2018, again, is something that's fairly unique, not just in West Yorkshire, but in the rest of the country, particularly where the hospice provider has taken a lead role in sort of facilitating and I'll use the word coercing the partners around what we think is really important agenda. So just moving through, I haven't got a lot of slides, so I will hopefully get through this quite quickly so we've got lots of time for discussion. First, I wanted to start with why, as a partnership, we believe that palliative and end-of-life care should remain a priority in terms of outcomes within Kirklees. There's a few facts that you may or may not be aware of, but in terms of the overall spend in the NHS, over 20% of everything the NHS spends is in the last year of somebody's life. So utilisation of health and social care ramps up the closer to the end of life that you get. Over 30% of people in a hospital bed today, and most days, are in the last year of their life. So again, in terms of unplanned care and the impact on our hospital capacity, again, this is significant. And approximately 30% of people in the last year of their life use some form of local authority funded social care. Again, one of the sort of triggers towards having better conversations with people about their end of life is when they start to utilise more social care. Building on that, just I suppose more of a general societal thing, I think it's fairly well recognised that care of the dying is seen as an indicator of the quality of care that provided for all sick and vulnerable people in the population. It's almost like a marker, how important, the importance that we give to people who are in the last year of their life is indicative of the importance we give to the care for older people. The experience of death is life-changing for many people, particularly those who are bereaved. It can actually affect their health and well-being and their life outcomes, depending on their experience. And then, just building on the quality position for a minute, more than half of the complaints that are referred to the Parliamentary and Health Ombudsman are about end-of-life care, and over half of those are upheld. So it's very emotive and a very important and lasting experience for people. So the theory that the partnership's based on is that if more people are identified as approaching the end of their life, and more people have what's called an advanced care plan, so that's actually an expression of their future wishes and their priorities, and more people have access to timely specialist palliative care, and their care is coordinated effectively, then more people can have great care at the end of their life and not die in hospital unless they absolutely need to be there or they want to be there. And that's really what we're trying to achieve as a partnership. That's just another way to express, and this is based on some national evidence, but another way to express what's really important to people in terms of what they would say in I statements around the care that's provided towards the end of their life. So moving further on then, this is a fairly busy slide, but you've had this within the pack that we've provided. It's a plan on a page around the programme that the Kirklees Palliative Care Partnership are running with. And I suppose it centres around what's bringing the partners to the table and what's committing them to the programme in the first place. So we're all passionate that more people in Kirklees experience great care at the end of their lives. That's our vision where we're trying to get to. And then the bottom of the pile is the organisations that are involved in delivering aspects of palliative end of life care, all of which that are part of the partnership, and all are signed up to something called the Kirklees Care Charter, which is one of the devices that the partnership's developed over the last few years. We've taken a sort of a quality improvement, an integrated quality improvement approach to this. Using that charter, we've actually done self-assessments within each organisation to identify our own areas for improvement, with, again, the view of being able to move some fairly explicit measures around the numbers of people that are identified, the numbers of people that have a plan of care, the numbers of the people that access specialist palliative care, the numbers of people that access hospital care in their last 12 months of life. And then one that we've got to work on, which is the experience of bereaved people. There's no systematic way at the moment of collecting that objectively for the whole system rather than from each individual organisation. One of the things that drives us and binds us as well in the work that the programme does is the experience of real people. So at every meeting of the partnership, we focus on an individual, real patient or family story of something that's either illustrating good quality outcomes and good quality care, or the opposite, so that the partnership are focused on what good looks like and where we can target improvements. Again, that's another way of expressing actually where some of the gaps are that have been identified by the partnership. It's true that not everyone is identified. It's true that not everybody has an advanced care plan. There's a lack of clear and consistent information depending on, again, on which services are accessed. Care is not coordinated and key information isn't shared with all professions involved in care all of the time. Not everyone has access to specialist palliative care. Not all the workforce is trained and confident in end-of-life care, and more people die in hospital than may want to do. So all of these things that have been identified are outcomes and outputs that the partnership are focused on resolving. So I've talked about some of the products. One is we've actually taken a commissioning role. One of the things we did back in 2018 as a charity locally is to step forward alongside the NHS and alongside the local authority to say that we would lead the commissioning of palliative and end-of-life care for local people. So one of the things that we've done through the partnership is actually to identify what the future service model would look like that would make some of the improvements that we're targeting and address some of the objectives that we're after. So I've talked about the end-of-life charter, again, which is available to you in your pack. It's a series of I statements that people and their families should expect when they're experiencing end-of-life care. We've taken this integrated approach to quality improvement that I've talked about. We've developed and improved our interface with all of the care homes and the care sector within Kirklees through an e-learning package and a care home workbook that is, again, really well used now through different establishments. And we've also been helping our colleagues in other organisations by developing handy guides to some of the, I suppose, the triggers and the entry level parts of the process, the identification of people, and then the, how to start the difficult conversation and how to introduce the advanced care plan. This is just some of the visuals of that. That's the model that we've recommended and has been approved by the Health and Care Partnership in Kirklees. That's the charter. as it stands, that has been formally committed to by all partners within the partnership, and again is an expression of our vision for what people should experience in the future. So what difference has it made? I suppose one of the things that, again, we're really proud about is that the work that we'd done prior to the pandemic put us in a really good place as a system to support more people in that period. And what we'd also done was we'd introduced, the Kirkwood had introduced additional services in line with that service model that we'd developed. So we introduced a care coordination service, we extended our community nursing service, and we employed an additional consultant in palliative medicine in the time leading up to the pandemic. And the work that we've done with the partnership has resulted in significantly more people being identified as being in the last year of their life, so that again an advanced care planning discussion can then be initiated, and even more, sort of 180% increase in the numbers of people that have had an advanced care plan when they died. A lot of work happened with care homes prior to the pandemic and at the beginning of the pandemic, where again better quality conversations happened about to identify people's wishes and to ensure that we could target the care that would meet those wishes. And the outcome of that was that actually more people were supported in the community by the integrated community care teams in community and primary care, by the Kirkwood and our specialist services. And the overriding outcome was that there were 40% more people supported to die in their usual place of residence during the pandemic than prior to the pandemic. Now, there are a number of factors that were at play there, but a lot of it was about the preparedness of our partnership and our system to provide the evidence-based care in that period. So there's been a tangible impact, but it's only the kind of start of the journey. We've got a long road to travel, and particularly there are links with the discussion we had earlier around reducing health inequalities and making sure that as far as we can, people, no matter what their identity, where they live in Kirklees, can have the same experience of end-of-life care, and that's something that the partnership are committed to delivering. And the Kirkwood continue as an independent charity to be committed to leading this work on behalf of Kirklees and are committed to improving the experience of local people. It's why we exist. It's what we're passionate about. Then just not to sort of try and battle you with science, but again, I know you're quite versed in looking at statistics and different presentations of data. This is a metric that we review at the Ageing Well Board. So the Palliative and End-of-Life Care Programme reports into the Ageing Well Board as part of the health and wellbeing structure. And this is one of the key metrics. So the numbers of people who have 3 or more admissions to hospital in the last year of their life is an indicator of how well that person's care has been coordinated and how well their wishes have been delivered. And you can see that there's a marked difference between the levels of people that were hitting hospital prior to the pandemic and during the pandemic. Now, we don't take credit for the whole thing. We were in exceptional circumstances. The whole system was ensuring that people weren't in hospital unless they had to be. But the special circumstances were that the capacity was available to support those people effectively, and we did. So in community services, sort of planned care was reprioritised to make sure that we could respond to people with more urgent needs. The Kirkwood stepped forward and again invested in new services through that period to make sure that we could support more people at that time. And another thing that the committee might not be aware of, but the availability of informal carers was increased because of furlough and because of, again, the way that people were living their lives, which had a massive impact on the ability to meeting people's needs, particularly in the last weeks and days. And it's something we feel passionate about, that things like, employment policies that allow people to care for people in their last days, or even going further than that, having a statutory right to carers leave to support somebody at the end of their life. It's not just important when somebody's been bereaved, it's important to be available to somebody in that very important phase of their life. But this is an absolute marked difference in a very important outcome that the partnership has helped to deliver in Kirklees. So what's next? We're doing more work which is about, I suppose, identifying the next steps we can take. One of the things that we think will be important is a quality of dying report that we are proposing to develop with public health, with public health with their help, which will include, for the first time, a comprehensive health needs assessment for palliative and end-of-life care for Kirklees, which, as a consequence of that, should confirm some of the assumptions we've got about underserved people within Kirklees, the Kirklees community, and help us to focus on their needs and reduce some of those inequalities. We're working with Healthwatch, to do a particular piece of work to identify what a survey of bereaved people might look like in Kirklees, and that's commissioned and will be delivered this year. And the care charter that we've talked about, that we are actively engaged at the moment with the Kirklees Care Association about embedding that care charter within care homes and within other social care organisations. And then the thing about advanced care plans, it's not just a numbers game. It's not just that an advanced care plan exists, it's actually what the quality of that plan looks like and how often it's updated. So the partnership is focused through our best practice steering group at looking and auditing different organisations' use of those plans. So I think we've been a bit cheeky here, and what we're saying is I hope I come across as being passionate about this. It's what drives me in my work. We've got a lot of partners around the table now who are passionate about the same thing. We think we're making progress, but there's lots more to do. And just in terms of the local community, we just want the needs of dying people to be as high up on the agenda as possible. So I'd like you to consider the way you could, influence that, within your own communities. It affects, people, families, their friends, but also the communities around them. The experience that people have. And then there are other more practical things. Emily and I are in a discussion about, where this features within, the health and wellbeing plan. It is there. It has been explicitly there. We need to ensure it's still explicitly there in the implementation of the strategy. It's certainly implied and mentioned in different places. We want the same, priority to be assigned. And then the way the health and wellbeing plan is structured or discharged is through starting well, living well, and ageing well boards within the health and care partnership. We'd even go as far as saying we believe at some point dying well is an outcome that we seek to, again, prioritise alongside those other outcomes. So I want to invite Helen in now just to, I suppose, share an experience of one of our partners within the partnership, and then we'll answer questions. Helen, are you with us?
Yes, I am, thank you. Yeah, the partnership, as Mike has explained, has been really successful. I think the success has been there for the driver, Kirkwood and Michael, but then the colleagues around the table. And I think some of the initiatives we've looked at of how we can work differently. So, for example, we deliver the discharge to assess service from Locala, and we've got colleagues now from Kirkwood looking at being embedded in that team, looking at how we can promote and support the trust to come identify patients who are end of life, how we can get people out of hospital more quickly through that integrated approach. And I think that shows a really good example of how we are working together. Same within our community services, where we have patients who are end of life and they're looking for not-to-tower responses. We work closely with Kirkwood and how we can support that palliative care approach. And I think some of that integrated working has really been successful, and you can see from the statistics there how we have improved in those areas. But we have a lot of work to do as well to continue to improve to support all residents across Kirklees.
Thank you both. Are you doing anything? No? Okay. We're open to questions then now, are we? Thank you for the presentation, Michael, and thank you very much, Helen. We'll start, we'll go the same order as we did before. Okay. Bill.
Yes, thank you. I don't wish to be hypercritical, certainly do not. But if I could just refer to slide 6, I think it is, which is the Kirklees Palliative and End-of-Life Programme slide, and the vision in the top box. And the vision is that more people in Kirklees experience a great care at the end of their lives. As a vision, I would suggest that ought to be all people.
Yeah.
I would just suggest that, because if you're aiming high, if you come a little bit low, you still hit a good target.
Quite right. I agree with you entirely.
I'm assuming you're aiming high. That's where we're going. Alison, then.
Thank you very much for your presentation. I read through the information we were given before I came today. So I've just got one or two things. Firstly, some people, and I know this from my experience with family members, they don't want to know how long they've got left to live. They just don't. So I don't know how but presumably, if you want them to sign up to an advanced care plan, then they're going to have to have some kind of inkling of how long they've got. So presumably that's kind of an issue for quite a few people. My second thing is, how can we help you get the message out there that people know that they can have access to the hospice and its nurses, and that they're more likely to be able to not die in a hospital as opposed to in their home or in your hospice. And my other issue is around capacity, in terms of if we're going to get the word out, and you've got this partnership with Kirklees, and you're hoping your vision is all people in Kirklees experience great care at the end of their lives. How is that going to happen? Because you're a charity, you rely on donations, £4 million a year you invest. How on earth how are you planning to keep that momentum going? And how can you deal with capacity if more people sign up to what you're saying, and you're going to help more people? Have you got the capacity and the means to do that?
There's an obvious answer to that last one, which we'll come to. I think the first point is really well made, and I think that good care at the end of life is personalised to the individual and respectful of who they are, and what's important to them, and what their wishes are. So again, there's no suggestion that an advanced care plan, for example, would be forced on an individual. I think this is about trying to explore what we know is best practice in delivering best outcomes, and encouraging better conversations between people in our community and between professionals and people about what's going on and what's important to individuals. An advanced care plan doesn't need to be done just at the end of life. An advanced care plan is for any stage of life. It's basically about a statement of, when it comes to the receipt of care, what's important to me, who am I, what are my goals, what treatment do I want, what treatment don't I want. It's and it can evolve and change on a daily basis. So I think we know, and we're using it as a measure, that if that plan exists, then there's more chance of that person's needs being met. But it's certainly not kind of everybody must have an advanced care plan. It's, I suppose, a skillful conversation exploring the benefits of having one for the individual. Going on beyond that, how can you help? You're part of this community, and I suppose the way that you can help is to help maybe dispel some of the myths about, particularly hospice services, but actually, palliative care. So the hospice is known in Kirklees as being the place in Dalton where people go to die. The reason why we changed our brand during the pandemic, actually, or our identity, was to start to try and explain to people that we're much more than that. The care that we deliver is actually in people's homes, in every street, every village, in every town in Kirklees. And our focus is, yes, it is about people who are not going to recover from the illness that they have. But every focus of the care is around their quality of life while they're living and the quality of life of those people that are affected. And that's what we're trying to do in the partnership as well. So the bit about the sustainability of the Kirkwood is as much about how we can embed good palliative and end-of-life care in all of the services that are available to people. So it actually starts to focus where our role is in providing great palliative and end-of-life care. But, and I would, because you've given me the opportunity, I would say that, we exist because we want everybody, quite right, Councillor, everybody to experience great care at the end of their life. That's what the founders of Kirkwood Hospice were interested in back in the early 1980s. We're still passionate about that now. We're only reaching about half the number of people that could benefit from our services. So we need to double the number of people over however long in the future. And that comes through campaigning, making sure that we've got the resources first, making sure that our services are sustainable, and then tackling, the people that are underserved, over a period of time. It won't happen tomorrow, but it's certainly something we're committed to.
Michael, just in between, if you just pop your microphone on and off, if that's all right, there's just in between. Liz, can we come to you? You've got a question, your hand up.
Yes, thanks. I've just got a quick question, actually. You mentioned about trying to keep people out of hospital, and you're working with Mid Yorkshire and CHFT, which is really good. But what about the other hospitals in West Yorkshire? Because if somebody does have to get admitted, it's not always to Mid Yorkshire and CHFT. So would the other hospitals, like for instance, BRI or St James's or Barnsley, etc., would they be able to access your advanced care plans so they would know what somebody's wishes are? And you mentioned about bereavement services and support. What support is there for carers who are family carers who are looking after people who are at the end of their life? Because it can be an absolute minefield to navigate through things and through services, as well as what you're going through personally when you're looking after somebody who is at their end of their life. Thank you.
Helen, do you want to come in? Sorry, I'm being chair.
Sorry, just on the about out of area hospitals. So we do have referral routes from all outside of hospitals through the same process that we do within Mid Yorks and CHFT. We are on site within those places, but we do have connections with, Leeds, Barnsley, Bradford, and those pathways there. So we would have the same service offer as we go through. And we also do within that team, we can do video links, or we've actually visited hospitals where we've needed to, depending upon what people's needs are. And in relation to advanced care plans, so that's everybody's business. So any advanced care plans that commence in hospital will be transferred through that referral route. And now we've got the Kirkwood part of our team within there, we would be able to offer a more supportive approach for people on end of life.
I just want to add one more thing to that. That again, the whole point of this is trying to get people known to services before they're admitted to hospital, and maybe then sent on to more sort of tertiary services. Certainly, the pathway on the way back's fine, but the evidence is about getting people known to palliative care before things escalate and exacerbate.
Can you pick up the bit about carers as well that Liz raised?
Yeah, Thanks, Councillor, for raising that. I mean, again, this might be one of those misperceptions or myths about particularly hospice services, in that our services are not just for the patient, they're for everybody that's affected by the illness. So that's anybody that's important to the person that's got the illness, and it's every step of the way. So as soon as an illness is becoming difficult and affecting somebody's quality of life, through to the end of life and then beyond, a lot of our services around the practical support to carers who are caring for somebody who's got palliative care needs or at the end of life, or the emotional and psychological difficulties of dealing with that, or just through to sort of practical, more, sort of the life changes that might happen when somebody dies. So a lot of our services are focused on the needs of those individuals as much as they are of the patients that we care for.
Liz, do you want to come back?
No, thanks for that. I think my question about the hospital was not necessarily at the start of being in contact with services, but actually throughout the whole of the care. And my question about carers was out of experience, which was why I asked. Thanks ever so much. Thank you.
Okay, Leslie, can we move to you? Yeah, okay. So this is something that I feel very strongly about, having had a lot of experience of this last year. And the one thing that I believe myself and my partner were amazingly lucky, that whilst there were delays in getting initial diagnosis because of hospital access to scans, when he was finally diagnosed with terminal cancer, my partner last December before last, he went downhill very quickly. But the team that came in to support were absolutely fantastic, because he wanted to die at home, but he went too quickly. And there's two things I want to raise. One of them is to do with La Carla, and one is to do with that amazing place called Kirkwood Hospice. He desperately wanted to stay at home, and we had the end-of-life meds, as you'd expect, but you can't administer them. We had to get the La Carla staff out. Now, on that particular time, 2 nights running, they were really short-staffed. There was one team of 2 staff on for the whole of Kirklees, so they took nearly 2 hours to come. And when they came, they were really frustrated, because they said, this keeps happening. When you get the end-of-life meds from your doctor, they keep forgetting to put in, apparently you need the sterilised water to mix with, to give the injection. And they then had to go back to the hospital to get it. So that was a really hard experience. It happened 2 nights on the row, and I have mentioned this before. However, the nurses that were coming from Kirkwood Hospice were amazing. And what was really lucky, we were due one of our regular checks from the hospice nurse, who could see that my partner's pain wasn't being managed. She said, we need to get him into the Kirkwood, into hospice. And I've said, I've tried that, but they're full, because obviously they're always full. But, well, I mean, mostly they were full, and they had slightly less beds because it was sort of still edge of COVID. I think it was 14, 15 beds at the time. But she said, we always give priority to people in pain in the community. And within an hour of her leaving me, she rang me up and said, an ambulance is coming. Now, he was going in there just to get his pain managed, but he went downhill too fast, so he was there for 3 weeks. So I was in and out of our hospice for those 3 weeks. And the last week, I was living with him in his room. Oh my God, it's just like being surrounded by angels. It was the most amazing experience. You have the privilege of being there in their transition. They look after you so well as him. And I have not got enough good words to say. I just wish there were enough for everyone to be in that place. But the one thing in the endless talks, as you can imagine, because I'm a chatterbox, I talk to the nurses often in the early hours of the night. They were saying the one thing they wish there was far more of, and I'm an ex-teacher, is education. We've got to get away from this taboo about death. You're born, you live, you die. And the more we can bring it into schools to talk about it, to not put it away, oh, we're going to be old and wrinkly, can't talk about it. Because I think most people make a will. Making an end of life, how you would like to die, where you would like to die. Like the whole of my family know we don't want any intervention when we get to the point where things are going wrong. So it'd be quality rather, than the other one. So I just think there is opportunities maybe to develop. I know it's a difficult subject for a lot of people, but it's part of life. And I just feel we need to do a lot more in our schools, however sensitive, to start the discussions. And people have been experienced it, maybe going into PSHE lessons or whatever, just to sort of say, let's not be frightened by it. Television and media don't help. I mean, there have been some good programmes, and those people who like reading books about end-of-life care that various journalists and things have written are very inspiring. But clearly that's maybe in a minority. But anyway, I just wanted to say the hospice was brilliant. And also they supported me. I've only recently finished bereavement counselling with them. And, wow, amazing.
What a fabulous accolade. I wonder, Helen, if there is something that you can pick up about the night team and just address that query.
Yeah, so we have seen a significant increase in North Tower responses for palliative care support. So what we're working on is to try and reduce the need for a North Tower response, and that's by ensuring that we can review the prescriptions that are in place, make sure that the care that's being prescribed to them is the right level of care, to make sure the pain medication is there so you don't have to wait 2 hours for someone to come out. So we have been looking at that and looking at how we can get advanced clinical practitioners, how we can engage with our primary care colleagues to make sure that we've got the right prescriptions and the right support plans, because it has been a challenge for us and it is an ongoing challenge. Sometimes we have a number of responses where we called out for one patient. So we've got to get that right, and we can do that by working together. So it is something that we are still working on and trying to reduce the need for that rapid response by having the right care in place to start with. And the other element we're looking at is around our self-management model, and part of that is how we support carers to be able to support the patients within their own home as well, where they've got the capability to do so. So we know it is an issue, but it is on our priority to resolve.
I just wanted to say I'm sorry that's happened, but thank you so much for sharing your experience, and I'll take that back to the team. Thank you.
Can we move on? You all right, Helen? Yeah, Kim? Nothing? Joe? Have you got any questions, Vivian?
No, Jackie, thank you, other than to thank everyone for the presentation.
Thank you. Just a few, Michael. I mean, I think you've had your patient experience here, and it's been really wonderful to hear that. Can I just ask? One of the things that we didn't get in the pack was how many people are actually supported to die at home, how many supported to die in a hospice, how many are dying in the hospital, how many people are dying elsewhere, because your targets and the progress that you've made against them are fantastic, like 60%, and 180% are fantastic, but haven't got a feel of how far you've got to go yet. So I wonder if that's something that you can perhaps give us afterwards, or unless you have it on the top of your head. But that would be really interesting to know, because without a doubt, people have felt that the service, particularly that the hospice are providing, is superb. We'll come to the partnership in a minute.
Just at a very high level, and thinking about deaths in hospital. Generally across the UK, it's about 45% of people that die in hospital. In Kirklees, the most recent year was 43%. If you've been identified as being in the last year of your life, if you have an advanced care plan, if you're known to the Kirkwood, last year it was 8% of those people that died in hospital, just 8%. So again, we know that, you know, when all of these ducks are in a row, then we can actually, you know, achieve a better outcome, and that will have an impact on the whole population. And in terms of the Kirkwoods involvement, again, last year it was 900 people that we supported at the very end of their life, which has grown by about 35% since prior to the pandemic. And this support is in different ways. So it is right from inpatient care through to actually purely care coordination. So somebody at the end of the phone helping a care package to be delivered. But that's how we've expanded our impact on, you know, on people's outcomes at the end of life.
Thank you. I thought as well, the way that you presented from the partnership, the vision, the gap analysis and the targets that you've actually identified, I thought that came over really strongly within your pack. Certainly very clear about that. Can I just ask about employment and the carers leave? You said that you would actually like you talked about dying well and actually having that as part of the well-being strategy. So, you know, you age well and then you die well. Is that where you're aiming to try and influence some of those bigger workforce things? How are you lobbying for that?
So the only practical place to have taken that so far, we've taken that so far, is the ICB, the West Yorkshire ICB. So I'm currently in a conversation with the Director of People, and her name escapes me now, about how we might develop some carer-friendly policies that enhance what carers leave policies might exist already, and make specific reference to approaches to people who are caring for somebody, you know, who's at the end of their life. That's a bit of it. That's an open door. So that's an ongoing conversation that was sponsored by Rob Webster, who's the chief exec. So that if we can start to maybe ask. The ambition there is if we ask employers who are part of that partnership to adopt those types of policies, then we might be able to influence other places. So that's the approach we're taking at the moment.
Thank you. And I promise this is my last one. It was just a very quick one. In your partnership, you talk about one of the GP federations, Curo. Do they cover the whole of Kirklees? Are all GPs part of the partnership through them?
So again, things have changed. So when the partnership was initiated, we had GP practices represented by the federations, but those, well, Cura still exists, but the My Health Huddersfield has disbanded. So it's actually the involvement of primary care networks now, and we're working hard to make sure that we've got consistent representation within the partnership through the networks.
So somebody from each of the primary care networks is part of your partnership?
Somebody's representing the primary care networks within the partnership, and then to back it out the other way, the Kirkwood have got representation within each of the primary care networks.
Brilliant, thank you. Yeah, that's fine. Okay, has anybody else got anything to add? Helen? Anything that you want to add?
No, sorry.
Okay. So it's for us then to say thank you very much for the presentation. Again, I think you've captured our attention. There's a lot of good practice that's obviously been identified there, and I think we'd be wishing you well with your dying well, a part of the strategy. So good luck. Okay. Michael, we're just going to carry on with the agenda, so but thank you very much for your attendance. Okay, last item on the agenda is our work plan. And I think, as you can see, we've got March mapped out. dentistry, in-depth look at adult social care, and I'll whiz round the what we've agreed with them. Or is it updated on the adult social care one? Is it updated what we've agreed?
No, that just reflects what
we said originally. Yeah, okay.
Happened.
So whiz round what we've agreed with both dentistry and adult social care, and then you can see from a panel's point of view the questions that we've posed to them. All right. The other thing that we'll cover in March, as we said at the beginning, was some discussion about the out of hospital for Calder and Huddersfield in particular, out of hospital support. We're looking at the business case for Huddersfield and Calderdale, and if you remember, we did talk about needing to understand what capacity there is out of hospital to accommodate the growth. We will be getting a data pack that will come mid-February, and we will then bounce it round us and have a look at what information there is there, but we'll discuss it in summary at the next meeting. And then April, we need to cover April, don't we? Yes, please, okay. Richard.
Right, so just read the March meeting, just for clarification. Do you want me to send members the brief that's been sent out, both for dentistry and for adult social care?
Yes, please.
Okay, that's fine. Yeah. So I'll send that out. Yeah. In terms of April then, we've had a request from SWIFT, Mental Health Services, to come forward with some work they're doing. It's transforming older people's mental health inpatient services. I haven't got all of the details, but it is something that they're looking to do. It's like a transformation programme which will impact not just Kirklees, but also impact Wakefield and Calderdale. And my understanding is that they have also scheduled discussions with the scrutiny panels of those authorities as well. So if you're comfortable with that, then we will obviously proceed. We will get obviously an overview in terms of what they're looking to do, but my understanding is it's some kind of transformation programme, so it's clearly going to have some impact in relation to their inpatient services for older people. And then the other request we've had is for the presentation of the Kirklees Safeguarding Adults Board report, which is on our work programme. To be honest, that has been something that we have overlooked a little bit. It's there. Obviously, it's a reflection of what's happened in 21-22. We're now in 23, so it will be, it is out of date. But I understand what they'll do is they will provide us an update, not just in terms of that report, but also some forward thinking in terms of some of the work they're doing going forward as well, as following the reflection of that report. And then the third thing, which I think you've already mentioned, Councillor Ramsey, was the work programme review. We do that as a matter of course, where we look back over the municipal year, reflect on the work that we've carried out, because that will then inform the work we're looking to then take forward to 23-24.
Is there accommodation somewhere for CQC data as well, for them to come along?
We had a discussion about that earlier and said that we would receive it, but not necessarily discuss it. That's what we had said earlier in the year.
Yeah, I've not approached CQC. I mean, I think the problem we've got with the work programme is that there will be elements in it that, just because of the time and the resources, that we won't be able to necessarily cover everything. I can write to them to get an overview. That's something we can do, but I suspect we'd struggle to get it actually into a formal meeting, and that's part of the reason why we have that review, because you will find there will be strands of work where we said we would look to cover that we haven't, and that's part of the reflection to understand why, because often, as you know, this is a panel that moves. We've got a certain amount of proactive work, but also there is an element of reactive work, and I think sometimes the reactive elements overtake some of the proactive elements, and that's something that obviously that's just the nature of the work of the panel.
I just wonder if we can, if there is information, we can at least have it read it, and then we'd perhaps respond if there's, you know, if there is something that comes up from that that feels more urgent or not.
I can make contact.
Yeah, okay, we'll make sure that we get the information, we circulate it, and then we can have the discussion at the next meeting as to whether or not, if we've got it available then, as to whether or not we then programme it. Leslie?
Yeah, I just wanted to ask, I mean, it was really disappointing last year because the April meeting didn't happen. I can't even remember why it was. I mean, we're still allowed to meet in April, aren't we, even though, you know, it's the month before elections.
I think from memory it was we just didn't have we wouldn't be quorate. There wasn't sufficient enough numbers, and I can't.
Yeah, it was really disappointing because I think we got really key things that we were going to, and I just really hope
we
that
will be
the
having
April
that
one.
meeting in April. Yes.
Thank you.
Right, so anything else? Anybody? In which case, I will bring us to an end and say thank you very much. And we finished slightly earlier than I anticipated we would do after all that stress we had. So thank you very much for all your questions again. Good debate. Thank you, Vivian. Thank you very much, Liz.